Well, so funny topic. It's the only one that's not very practical. To get ready for it, I did a search in PubMed for all the papers published since January 1st, and there are 57, some of which are Turkish, but that just seemed to be impractical to go over. So I thought I'd pick a couple of things just to touch on. The first thing to do is to get us refocused. So we're not going to go over everything, just a few things. One of them is first assessment, which is really emergency department work that's going on, which actually has proven to be, I think, quite helpful and will simplify things a lot. The second is working out the prognosis of vasovagal syncope and why I think will enable us to deal with patients as individuals instead of averages. And then the third, just very briefly, why do people faint anyway? So the first is, much of what Dr. Sutton was talking about was not actually Heart Rhythm Society. It was the American College of Cardiology. The HRS document is now 5 years old. And nonetheless, there are now all these societies that have gotten together and published their individual documents. The only one that's an outlier is Canada, because the Americans don't want us, and neither does Europe. We just seem to be sort of the North Korea of the syncope world. Everybody says address the risk and cause. You've got to get both prognosis and diagnosis when you first see the patient. Admit that there's a good chance you won't know why they're fainting, but make sure you know that they're safe or they're not safe. And both documents have got a lot of knowledge. There are a lot of tables and lines, but they don't actually have a lot of wisdom. That is, what practically can I do in the emergency department? Been a lot of work on risk scores over the last 15 years, and they haven't really panned out for many reasons. Is anybody here an emergency department physician? Good. Good. I can make my usual comment about knuckle draggers. So there is one that's working out. I had no part in. My name is on it, but I have no idea why. But I had no part in it, except I smoothed it through ethics. But it's from Ottawa, and it's by a brilliant guy, Venkatesh Theraganasambandam Murthy. So he has done fabulous work. It took a ton of work. And he devised a syncope risk score that started with 4,000 patients, and it was multi-center, multi-provincial, so much more likely to be externally valid than most of the earlier scores. By the way, don't take notes. There's no bottom line. So he's actually done this now. There's been probably 10,000 patients enrolled in it so far, including follow-up data to validate the scores. So he's developed it, he's validated it, it's being implemented, and it's in guidelines, in the emergency department guidelines anyway, in Canada. And so these are the points. This is a score. I'll show you the data on the next couple of slides. But the important things are that you just add up the points. These are statistically valid. It's always useful looking at scores because scores tell you how doctors think, because we actually, in our heads, use scores. We say, well, it could be this, could be this. On balance, probably it's this. All a score gives you is a numerical balance. And so if you look here, how do you get a really low score here? Well, what you got here is the word emergency department. Doctor thinks they're likely to be vasovagal. Down here it shows up again, likely to be vasovagal. If an emergency doctor thinks it's vasovagal, it's probably pretty safe stuff. So how does this work out? Well, here you go. So this is a risk of a serious adverse event, which includes needing a pacemaker, which for us is a beneficial event, of course. And this is the theoretical distribution from the derivation group. And this is what they look like in the validation group. And this is within a month, and you can see here, almost nothing happens if they're in the low risk group. And the more points you get, the worse things are. And this has been published as a table. Not me. Okay. So what are these events? Well, actually, a lot of us here are arrhythmia specialists, and everybody's focused on arrhythmias, even though probably it's only 5 or 7% of the cause of syncope at the most. This is the lowest risk group, so scores of -3 to 0, I think. This is a medium risk group, and this is the high risk group, and he just followed them for 25 hours after they arrive and emerge. The reason why earlier scores haven't worked all that well is because emerge doctors threw in people who actually, had a cardiac arrest and emerge after fainting. They mixed up what they saw with the prognosis. The first 6 hours, most of the stuff that happens, even in the high-risk group, is going to happen probably before you can get down to emerge to clean up what the registrar did. And then while you're on the way down to emerge, figure out how you're going to get from about here to about here. What kind of monitoring strategy is reasonable until the bigger studies have been finished. But this is where things like patches will come in, almost certainly. So here we go. Drag your heels, watch them emerge for 6 hours, and then set up some kind of arrhythmia diagnosis routine. Remember, syncope is a devastatingly safe thing to have, right? Almost nobody ever dies from syncope. There is a death rate, though. So my question to you all is, here's one. So is syncope a risk factor for death? Yes or no? So yes, put up your hands. No, put up your hands. Okay. So we did a study in Alberta. This is actually proportions of patients. There were tens of thousands of patients. It's an administrative study, sort of like the Danish studies. And but for every 100 patients who shows up and emerge, we admit 15. And this is actually a national average. 15% get admitted. The UK is probably 30 or 40%. 50% in the Reed study. 85% home. And of the ones that get admitted, so 5 are sent home with syncope as a diagnosis, 10 are sent home with another diagnosis. You'll notice that nobody dies in hospital, and it's true, very few do. What's interesting, though, is we did this to do a propensity study to see why it was that patients got admitted. So, if you dredge enough data, you can come up with a score for anything, and a propensity score is, they're just the statistical factors in your heads that lead you to admit patients. And it turns out that the more likely you are to admit patients, you know what, you're doing something right, there's something in your head that's working, the more likely they are to die in hospital. If you take the same patients with the same logic that you're using, but you don't admit them, actually they die too. So there's no evidence that actually hospitalization helps. What's really interesting, though, is what is going on in your heads when you decide to admit a patient, or when somebody decides to admit the patient. What are the factors? These are the factors. Right? So these are the statistical factors involved in why you think you should admit a patient. Hypertension. Fair enough, maybe they've got cardiac sinus syncope. Myocardial infarction, heart failure, we're on safe ground. Rheumatoid arthritis, ulcers, liver disease, paralyzed, dementia. This is why people get admitted. They don't get admitted for actually arrhythmias. You think you're doing that, but you're not. And so then if you go back here, if this is adding up all those factors, and if you strip away all those factors, what you end up is down here. If you get rid of the comorbidities, actually, there's almost no death rate. So what syncope may be is just good luck. Patient faints, they come to the emergency department, somebody says, right, I forgot about you, there's a lot of stuff we should be sorting through. But it doesn't look to me that syncope is much of a risk for death at all. And if you then look at what people die from, okay, fair enough. Chronic, and remember these are administrative data, chronic ischemic heart disease, okay, maybe they have VT. Acute MI, lung cancer, smoking, stroke, people are not dying from rhythm problems. And in fact, in Venk's study, where he has many thousands now, there are very few fatal arrhythmia deaths. It's everything else. So syncope is associated with death, but is not the cause. It's just what brings people to our attention. So if you're consulted to go down to Emerge to sort out a syncope patient, I think this is where the data are going to take us probably within a couple of years. Drag your heels. Something might happen for 6 hours so that then you won't have to see the patient. While you're going down there, sort out how you're going to do something practical for the next 2 weeks to make an arrhythmia diagnosis. Lots of patches on the market now. There's studies ongoing. There are at least 2 studies ongoing now that I know of. Work out the Charlson comorbidity score. It's an easy thing you can download. It's just a little checklist. If they have a low score, then send them home to their GP to work out. If the score is high, consult the internist, because they don't need. Arguably, cardiology is the worst place to admit a syncope patient because the older ones have so many comorbidities, they don't work well on our kinds of inpatient services. They need a more general approach. So does this really work? Actually, it really does work. In Canada, we only admit 15% of people. Our mortality is the same as everywhere else, and only 1% are readmitted in 30 days. So you wonder why we're not enthusiastic about syncope units. We don't have the problem that the Americans and Europeans and England, separate from Europe, has. Why do we have these numbers? Actually, we have these numbers for 2 things. First is, at least in Canada, our Emerge docs have a 5-year Royal College training program, right? So they're really good. They're not GPs who end up in Emerge for a few hours a week. These are really well-trained, by and large, young people. As much as it's a frustration dealing with them, sometimes they're usually right. The second thing is, if you look at the number of hospital beds per capita in Canada, we're 30th out of 34 in the OECD. So the Emerge docs have drummed into them every day, don't admit, don't admit, don't admit. And so it's a whole different philosophy from the States, where admit, make some money, admit, don't get sued. In Canada, don't admit, we don't have the beds. Because we don't. I think Albania has more beds than we do. Okay, so let's focus a little bit on vasovagal syncope. This is lots of curves like this. If people haven't fainted in the preceding year, but have the diagnosis, they're very unlikely to faint again within a month after being randomized in a study. And if they fainted at least once, then it looks like this. But can we get any more accurate than this? And the answer is, we can talk about single patients, but it's going to take me 5 slides to get there, so bear with it. And some has math in it. Sorry. Okay, so this was a paper we published a couple of years ago, Clusters, Gaps, and Randomness. And the question is, how do you know that syncope is occurring randomly over time? And the answer is either very complicated or very simple. And the simple approach, this really is true, is just to add up the number of faints and plot them against the length of time. And if it's occurring randomly in time, there'll be a straight line, and the slope is just the frequency of fainting. And then if they stop fainting, they have a gap. And then they start again, maybe at another frequency, and then maybe they change into a third frequency. And that's all you have to do. If you have a patient with recurrent faints, it is really this simple, and I need to thank Gert van Dyke for this. Just plot it like this. The question is, what does it really look like? And what can we learn from this frequency? So these are some patients from one of our studies. And if you look down here, right, those points are all on the line. This patient is fainting with one random rate over time. And maybe this one is as well, and maybe this one is. But then you start looking down here. For example, patient was randomized here and had been fainting frequently enough to be in the study. Look at this, nothing happened for 3 months. And then boom, took off like crazy and then kind of slowed down. Same thing here. fainting like crazy, bit of a pause, started again. Same thing here. And so that's a cluster, that's a cluster, there's a gap, and a gap there. And actually, if you look at them, you see them in that light, straight line there, bit of a pause. You can start picking these things out all over the place. So there are really clusters with sharp edges. But what does it look like in the cluster? That is, what can you learn about the patient in front of you, Dr. Sutton, who is fainting? Can you learn something about when to tell the patient that they're better? And the answer is actually, yeah. If you look at this curve, for those of you who remember your chemistry, that's a mono-exponential decay. You see that in enzyme kinetics. You see it in the breakdown in, for radiation. There's an equation here. It's called the Poisson equation, and it gives you a rate constant. And every process that occurs randomly in time has a rate constant. And so we looked at a bunch of our patients. That was one of our patients. Here's one here that's fainting randomly over time. Another one. Every single one we looked at had a really, really tight correlation coefficient, usually R squared, if that means anything to most of you. It was over 0.9. It was really tight. Some patients didn't fit it so well. There's one factor, but here is two different processes you put in. So patients fainting frequently and then slows down. The nice thing about Poisson, this is the French guy from a couple 100 years ago. The nice thing is this is a random occurrence. You know it in radioactive decay, there's a rate constant there, so every patient has a rate constant. And that has to have a biological cause, right? Everybody's different, so there's something different in people's makeups. And what's cool about it is the rate constant is actually just the average, it's the mean, and it has a confidence interval. So once you know how frequently people are fainting, you just say, okay, I don't know if what I'm doing is going to work. Actually, you don't say that. You have to administer placebo, and you say, what I'm doing is going to work, and I'll have you back in how long out? Long enough out to know if their rate constant is stopped, and that's easy to sort out. It's usually about 3 times. So whatever their frequency is, multiply by 3, that's when you get them back in the clinic. And so you now have an n=1 target that you can address therapeutically. It's not just a rough average anymore. And how well do people do? Actually, you know what? Doing clinical trials in syncope is one of the most frustrating things you can imagine. You'd think you need 20 people. You need 200, and most of them quit anyway because they're not interested. And the reason is people get better, a lot better. That's why we all still have jobs. And this is a trainee that we had, Payam, and he looked at the control arms of randomized trials, the control arms, right? So theoretically nothing was happening, and he looked at the frequency before they're randomized and after they're randomized just to say what happened. And the answer is, if this is 1, so the frequency before is the same as the frequency after, in fact, all the studies had a big effect. On the whole, about 65% of people who had been fainting multiple times before per year stopped. So you're all administering a powerful placebo effect. And there's a vast literature on placebo. It's got solid neurophysiologic and genetic and anatomic correlates. It's a real physiologic thing. This is just one study from 20 years ago, Penny Flavari from Greece, right? So she randomized patients to 2 beta blockers and placebo, and what people remember from her study is, beta blockers don't work because they're the same as placebo. But that's not the real truth of the study. The real truth of the study is, this is how frequently they were fainting before they got a placebo. That's how frequently they're fainting after they got a placebo. There's a big drop, and you see it in all the studies. There's a study from Rome, Dr. Ammirati and his colleagues about 20 years ago, randomized people to pacing versus beta blockers. the way they set up their study, pacing could not possibly have worked. It looked just like VPS1. And yet, pacing did much better than beta blockers. So an invasive, painful procedure actually is better than a pill. And so I just want to leave you on two little things. One thing, there's actually thinking now that it may be genetic. Lots of papers on candidate gene searches, this gene, that gene, on TIL testing. Most of them, they're not adequately controlled by and large. What we did though is we took 7 families with multiple fainters in multiple generations, 160 people, took forever to get them, and we looked at a dozen candidate genes that made sense ahead of time. They were signaling genes and serotonin genes and endothelin genes, that sort of thing. And what we got were 3 actually that popped out. So this is just the way the geneticists say serotonin 1A gene. This is the main serotonin receptor for heart rate and blood pressure. And these are different alleles. The C allele in male for this for men. So this is CC, 2 genes, right? CG and GG, and as you can see, this is birth here. If you are GG and a man, the chances are you're not going to be able to avoid your fate. Whereas if you're a CC, you're not going to faint at all. What's interesting is it doesn't work for women. It's not about the nail. It doesn't work for women here. And this is true for all 3 genes that we found. Out of the dozen, 9 were totally negative, completely totally negative, and 3 popped up pretty strongly. And this is sort of what they look like. There's this serotonin receptor gene, the main one for heart rate. This is published in Syncope. And then the serotonin transporter, right? So fluoxetine, drugs like that. And then this is a really interesting gene, catechol-O-methyltransferase. You know what it does? Breaks down dopamine, the happy gene, right? So serotonin, dopamine, they're all involved. And they have different effects in men and women. Don't know why. I guess we shouldn't be surprised that there are differences between men and women. Thanks for sexual dimorphism. And thanks for waiting for your break.